This conference will now be recorded.
Good afternoon. I just wanted to introduce myself real quick. I'm Denise Wilson from ORALA, which is Oklahoma Residential Assisted Living Association. We started our association back in early 1980s, and the reason our name is Residential Assisted Living Association is that was when, before the assisted livings are what we know them as today. Then we had residential care and just a few little assisted livings starting. We did not have the big corporate facilities that you see now and most typically know as your assisted living. We still have a few of the small assisted livings, you know, the 5-6 bed homes, and those have been in our membership as well. Right now, our membership mainly consists of residential care, and majority of our members serve the mental health clients. I like when I'm in person, I can kind of get to know who we have in our audience and know your history a little bit better, how many have actually ever seen a residential care, how many know what a residential care facility is. There's a good myth about residential care, similar to nursing home. Generally, when you say nursing home, everyone kind of has an idea what a nursing home is. They've seen a nursing home, they've been to a nursing home, they've had friends or family that have resided in a nursing home. So typically you say nursing home and it's kind of one general thing. There's good and bad in nursing home, just like there is in every facility type, but generally you know what a nursing home is. When it comes to residential care, that's totally different. Residential care is different in each state. Some states, residential care is much more what we see in Oklahoma as an assisted living. In other states, residential care can bill Medicaid. In many of the states, Oklahoma is not the case. If you are or are not aware, residential care is private pay only. There is a wide range of fees in residential care from as low as $750 a month up to $3,000 a month. A lot of the residential cares that serve the mental health clients have a lower monthly rate out of necessity. A lot of our residential cares that serve mental health clients are relying on their Social Security checks to pay for their rent. There is no assistance for them unless the few homes that have a contract with the Department of Mental Health can supply a few extra dollars for that. So majority of those residents are relying solely on their disability checks. We have some homes that serve the senior population, and those do tend to have a little bit higher fees. Most of those are small homes, but again, they are all private pay, unlike nursing homes, and then of course assisted living is divided. At any time, if anyone has a question, feel free to interrupt and unmute yourself. You don't have to wait for the end. I'm fine with questions along the way if you have any. One of the big things I want to make sure you're aware of is just please know who the residential care facilities are in your area. Hopefully you have some good ones. We do not have very many left in the state. Each year we lose homes, unlike the other facility types where we gain homes. We are down to less than 40 residential care facilities in the state. A lot of that is simply financial. As I already explained, the fees for residential care, there's not a lot to it. Usually when I do these in person, I get several people with shocked faces and say, why do you do it? How do you survive? In all honesty, most of our residential care facility owners have another business that is helping with the res care. It's something they have started for a long time ago. They've grown up in it, their parents did it, or someone else in their family did it, and then they have just kept the business going. It is not a very lucrative business at all. Over the years, we have had more regulations placed upon us. They keep increasing just like yours and everyone else's as well. We were grandfathered in with Osbelka in 2011, and so all of our administrators are licensed now. They used to be just certified. They would take a 50-hour course and have a certificate, and then they could be an administrator. Now that has changed, and it helps us hold our administrators more accountable. So if there's any bad actors, they can be held accountable, such as you are and assisted living administrators as well. Residential care facilities have several different looks to them. A nursing home, again, as I mentioned earlier, typically everyone knows what a nursing home is. They kind of have that image of a nursing home. Generally, they're a large facility. Generally, they're all private or semi-private rooms. They kind of have that same structure and look to them. Residential care is not that way. We have residential cares that are simply 5 or 6 people living in a home, more what you would think of as a group home setting. And they can be, in any neighborhood if the zoning allows that. We have several in Tulsa areas, several in other residential areas. You wouldn't know any different unless you happen to know it's just a home. A very home setting, very family type setting, which a lot of residents enjoy that structure. We also have them anywhere in between that and large facilities that either were nursing homes in the past or even sometimes they were hotels in the past, and they are licensed for up to 75, 78 residents. And then we have facilities anywhere in between. As I mentioned, they do have to have a licensed administrator. They are required to have staffing 24/7, awake staffing 24/7. They do have to have inspections by a plumber, by an electrician, by the state fire marshal. They do the fire drills. Several of those regulations similar as what you will see in assisted living and the nursing home. While they do not have a physician, a house physician per se, they do have to have an agreement with the physician for emergency medical care. If they do not employ a nurse, which very few do, they have to have an agreement with a quarterly RN. The purpose of this quarterly RN is, one, to come in quarterly per the regulations. That's why we typically just call them quarterly RN instead of just RN consultant. And they review the meds, review the patient's charts, the physician orders, make sure nothing has been missed, and do a quick oversight over the residents just as an extra set of eyes. In residential care, they're not allowed to keep residents that require any routine nursing services. Therefore, most of them do not employ a nurse. There are a few facilities that are either owned by, their owners also have another facility type, so they do have a nurse on staff, or they have other businesses and employ nurses as well. Very few residential cares have a nurse on staff, but there are some that do. If they are a large facility or if they are serving a resident with a special diet, then they are also required to have a dietitian. Most of them do not do special diets unless they are required to do so. Residential care facilities do have to have CPR training, or their staff have to have CPR training as well. And most of them use a mat. Some of them have CMAs, but a good majority of them have mats. A lot of them will also employ long-term care aides. There is a certification for a residential care aide, but we no longer have any training programs for that. So you see very few residential care aides. You can employ a long-term care aide, and as long as you keep the certificate up for those, then they are eligible to work in residential care as well. The big difference between a client for residential care is they have to be ambulatory. Does not mean that they cannot have a wheelchair or cannot have a walker, but they must self-ambulate or self-transfer. If there's a fire, then they have to be able to transfer on their own to their wheelchair to get out, cannot need any assistance. So you cannot have a one-person assist, a two-person assist in residential care. There are a lot of different myths, different ideas of what a residential care client is, like I explained in the beginning, because it varies state by state. Typically, a nursing home, we all know what a nursing home resident seems to criteria is for that, and assisted living, but residential care varies a little bit state by state. I encourage you to know the residential cares in your area because they can be a referral source for you. We have had lots of residents in residential care that they need a surgery, they have a hip replacement, they need a knee replacement, they've had a wound that got infected and needed some IV treatment, they needed to go to a swing bed for a few weeks, and then they come back to residential care. If the residential care has a good relationship with the nursing home in their area, they refer them to you for their 6 weeks of their rehab or their recovery after their surgery. The resident likes it there, they come back to res care, then you're going to be their first choice where they want to go when they no longer qualify for residential care. Most people like to think that we have a triangle of, a ladder of types of care in our facilities. Res care meaning the entry level, and then assisted living, and then nursing home. In all honesty, it really doesn't work that way due to funding. Res care is the entry level. It does provide the least amount of services, but majority of people do not go from residential care to assisted living because they cannot afford that. So most people in residential care, once they either get to a level where they can no longer be independent enough in the res care, then they're going to go to a nursing home. So nursing homes are a great partner with residential care. Sometimes you will get someone in a nursing home. I've seen it several times actually. You know, there's been a spouse that has passed away. The other spouse health has declined. They've been neglected. They haven't been able to take care of themselves. They get to a point before someone is aware of it, whether family comes in, APS comes in, someone comes in and realizes, oh my goodness, this person's not able to take care of themselves anymore. They're put in a nursing home. Well, once they're in that supportive environment, they can actually recover quite more than you would expect, and then they can actually be transferred out to residential care because they really don't need the full services of the nursing home. Gives you a bed to take care of someone that does meet your criteria, and then when their situation declines more in res care, then they're able to come back to the nursing home. So it can actually be a referral source for admissions and discharges, whether you realize that or not. The services that are provided in residential care, they do have the 24-hour staffing, as I mentioned earlier. They have an administrator. They have someone that is passing meds, whether it is a MAT or a CMA. They are provided all of their meals each day. They're provided a snack each evening. All of their meds are supervised. You can have a few that can do their medications themselves if they are signed off by the physician. That's few and far between in res care. Their housekeeping is provided. Their laundry services are provided. We help them with money management, transportation to and from doctor appointments are provided. A lot of the services that are all inclusive, where even in assisted living they are billed for separately, such as the laundry or the transportation, all of that is included in residential care. Another thing with residential care is that they actually have to have their furnishings provided per the regulations. Assisted living, you know, you bring your own furniture in, you basically rent an empty room. Residential care, all of that is provided. You're welcome to bring your own if you so desire, but majority of the time they don't have it or don't have the availability to do that, and it is provided by the facility. They do have resident council meetings. They have resident trainings that are required as well.
Is there any slides we're supposed to be seeing, or is this audio?
No, I apologize. It's audio only. I was not able to get the slides ready for the presentation. Residential care is very entry level. A lot of the services are provided. If anyone has any questions, if anyone is unclear about what residential care is, I welcome those questions. We do have, of course, our chapter 680, and in that, a lot of people don't realize, but there's lots of references to other chapters as well. They still have to follow chapters 257, the food guide, just as the other facility types do. They have to follow the regulations on the nurse aides, a lot of the same regulations that are seen in other facility types as well.
No question?
One of the myths about client care in residential care, I think, is usually I always get a question about diabetes. If a diabetic can live in residential care, a lot of times people think if they are diabetic, they do not qualify for residential care, and that is not true. It depends on their level of care. For a diabetic patient, if they can take their own blood sugar test, if they can administer their own insulin, if they're on insulin, then they can still live in residential care. The moment when they can no longer take their own blood glucose test, or they can no longer administer their own insulin, that is when they no longer qualify for residential care. Or if their diabetes is out of control. If you have some A1Cs that are extremely high, they're a brand new diabetic, those kind of things then will take them out of residential care level of care. Someone on a walker or wheelchair, they can still be in residential care as long as they can ambulate. Someone on oxygen can still be in residential care. Someone with a nebulizer, as long as they can put their own medication in the machine and do their own treatment, then they can still qualify for residential care. A lot of times they will, keep the nebulizer in the med room or a specific place that the resident comes to and does that. Others, they can do that in their room. So there's a lot of misnomers about what level of care is actually seen and what they can actually do in residential care. Does anyone have any questions about that?
I have a question.
Yeah.
How frequently does the state hold a meeting at resident care?
Does the state hold a meeting?
Yeah. I have
No.
How frequently is the Oklahoma State Department of Health required to hold a public meeting in the licensed resident care home?
I have never seen them do one in a residential care home, and I personally owned one for over 10 years.
All right, thank you.
You're welcome. Each facility is required to have resident training and resident council meetings, but not the state come to the res care and do a meeting. Any other questions? Anything you may have seen in your regulations that you had a question about, that you weren't sure about, or that struck you as being odd, or that you're just curious about? Again, they're kind